Hi, my name is Bright Easy, and this presentation is for Nursing 5102 Basic and Clinical Pain Research. The presentation today, we're going to be talking about a clinical review of transition from acute to chronic pain after surgery. Next. The study and background, or perhaps the overview. Over the years, there has been an increase in reliance in opioid use, specifically to treat acute post-op pain. And post-op pain is most ubiquitous and resolves mostly within 1 week or of having the surgery. And as we all know, untreated and improper treatment of post-op pain results to persistent or most extremely chronic surgical pain, or in short, CPSP. There's more than 20% prevalence in post-op pain resulting to disability and dysfunction in everyday work life. Chronic post-surgical pain is currently at the ladder of public health crisis because it has contributed to the existing opioid crisis that we all read and hear about today. Unlike other types of pain, acute post-op pain has been more has more potential to be controlled better because it is ionotrogic and specifically planned as opposed to other kind of pain. Next. What's the underlying research question here? This particular series aim to review, it's more like a clinical review of the post-op pain epidemiology, the basic science, and the current recommendation for management, and most importantly, the mechanism of transition from acute to chronic post-surgical pain. And what's the underlying definition? To be honest with you, there is no conclusive definition, just kind of definition everywhere by different research. But for this particular purpose, this particular study has been published by Glare and colleague, who will be defining chronic post-surgical pain as pain originating from the site of incision or related to surgery that has lasted more than 1 month. Like I said, definition may differ due to existing comorbidity of pain history or perhaps pain syndrome. Next. What are the clinical features of this particular chronic post-surgical pain? Chronic post-surgical pain is often characterized as aching pain, especially when it has lasted for a very long time. Painful experience of chronic post-surgical pain change from familiar to complex pain syndrome, thus being, adding to a lot of daily struggle and also making lives even more harder to live. And chronic post-surgical pain sometimes are referred to as causing pain in other areas other than the pain, the surgical site. Next. What are the underlying history and the prognosis of chronic post-surgical pain? Little studies exist that discuss CPSP, thus difficult to predict this pain. On the basis of evidence, chronic post-surgical pain does appear to often resolve by the end of the first year post-surgery. In one study, about 42 of the people that participated developed pain syndrome after 12 months after surgery. So it's kind of like not consistent, perhaps can last even more than 12 months. And in some occasions, it has lasted more than that. So, next. What's the underlying mechanism of transition from acute to chronic post-surgical pain? In animal model, as we've discussed along the whole semester, and we've read in articles and everything, animal models has been used to by researchers, and they also has been used to develop a precise model to actually show the underlying mechanism of chronic post-surgical pain. And it's all about the sensory aspects of pain that are being propagated by a various bidirectional network of neurons that transmits a variety of noxious stimuli, including the A fibers and the C fibers to the spinal cord, specifically to the spinal cord dorsal horn. Noxious signals are modulated and shaped at various levels of the nervous system, including the powerful descending pain pathways that we're going to be talking about in the next slide. Next. What are the mechanisms of transition from acute to chronic post-surgical pain, like we're talking about before? The nociceptive efferents are neurons that has been sent in form of injury to the spinal cord dorsal horn tissue that had caused the damage, leading to the input of the spinal cord dorsal horn that results to the release of all these neurotransmitters, the glutamate, specifically, including with NMDAR, which leads to the release of calcium, or perhaps the influx of calcium and sodium to the receptor sites, to the postsynaptic neuron, causing more excitatory signal, which in this case is pain. So research has proposed that if we can stop the influx of calcium and sodium during this pain mechanism, we will be able to terminate certain pain transition from acute to from acute to chronic, which is in this case from acute surgical to chronic post-surgical pain. Next. What are the behavioral correlates with this particular chronic pain? Evidence from neuroimaging has shown that certain brain regions that control emotions and motivation are hindered. And these particular regions are in general referred as the corticoids, which we're going to be discussing in the next slides or so. And a study that had followed up patients with acute back pain for at least 3 years found that the anatomical characteristics of the corticolimbic circuitry, which I just mentioned earlier, that helps control for emotion, are a dominant predictor for chronic post-surgical pain, and is contributing about 60%. That's a lot, and it's sort of concerning. Next. The behavioral correlates continued. Additive substances such as opioid alter the plasticity of the corticolimbic circuits, and conversely, leading to persistent pain. And this persistent pain promotes opioid reward. The more pain you have, the more you want to quell the pain, and the more you need that opioid medication to help quell the pain, and the more dependent the patient becomes. The increase in opioid reward measures in mice model with neuropathic pain was specifically dependent on signaling changes in the group of the corticolimbic neurons. And this particular neuron has been demonstrated to contribute to the reward mechanism that leads to the need for more opioid when in pain. But like, would you blame the patient? They're in really bad agony and they need relief. So the question is how could we interject or interfere with this particular reward system to be able to not even get to that level of looking for reward to be able to feel better, but perhaps eliminating the aspect of even letting it transition to that level. Next. What are the predictors of chronic post-surgical pain? There are 5 core risk factors, and they have been compartmentalized into demographic, generic, clinical, surgical related, and psychological. With regard to demographic, that could be age, gender, marital status, employment status, education level. And with regard to genetics, it could be considered as the mutants gene that actually contributes to like pain, feeling, and all that stuff, pain intensity, such as COMT, and even OPRM1 and GCHI, and so on and so forth. With regard to the clinical features, these are like the surgical factors that contribute to this pain, the analgesic plan, preoperative plan that had happened. With regard to psychological, it's the fear, the anxiety of surgery, depression that might come afterwards, and the pain catastrophizing. Next, what are the proposed preventative methods and treatment by this review? Some chronic post-surgical pain risk factors are modifiable, such as body mass index and preoperative pain in terms of instituting a plan before even a patient goes to surgery. And other chronic post-surgical pain risk factors are non-modifiable, such as demographics, genetics, and pain sensitivity. Optimizing preoperative pain management is the key to reducing the incidence of CPSP. However, evidence remains elusive with regard to the pharmacological intervention, which in most cases, opioid has been used, and it has now really shown to prevent that chronic aspect of the pain. Implementation of transitional pain clinic has shown to be helpful, evidence-wise, to actually help this patient transition, not just from hospital, but from the medication that we introduced at the hospital before going home. Next. Conclusion. As we've known and heard, poorly controlled acute post-op pain is a predictor of chronic post-surgical pain. Medications available to treat acute pain are mostly ineffective at preventing it, thus increasing the risk of chronic post-surgical pain. Opioids are too often overused, particularly in post-discharge period. However, establishing pain clinic as a bridge to post-surgery would be really helpful in or bridging this gap of transitioning from home and like trying to maneuver through the whole medication being introduced, specifically opioid, different kinds. And also, as we've talked about, undoubtedly, CPSP is similar to other chronic pain, therefore requiring comprehensive biopsychosocial approach to treatment, which mostly do not has not been frequently used in the clinic, and we should start using that. Thank you so much. I'll be glad to answer any of your questions, and thank you for listening. References. All right. Bye bye.